The first topic for the workshop will be NIPS versus invasive. And for that, I invite our speaker, Dr. Ashutosh, who is a fetal medicine expert from Artemis. Can I have the CV of Dr. Ashutosh at Artemis Hospital? Welcome you, sir.
I'm really very honored, and I really thank Dr. Neeru ma'am to give me this opportunity to present my side of the story as far as we're talking about this NIPS and NIPT. Okay, so now let the ball rolling. So what we can talk about is this, that whether it is a testing or a screening. So we can talk about it, right? So this is what we get is this, that the small, very very small amount of a DNA, which is something around 200 kbs, right, which is from the trophoectoderm, which gets into the maternal blood, and therefore we collect all these things and identify it to be, and then we look around and then we do the NIPS or NIPT, right? So I want you to really look around. Can I have this thing? Uh, can I have a pointer? Yes. So look around in here. So probably we need to understand that there could be some mosaicism across. Okay. So the mosaicism can be generalized both in the placenta. We can have in the placenta, and we can have a generalized, and then we can have a fetal mosaicism. Right. So probably we are going to start from this background. Right. So depending upon this thing, probably we can identify that NIPT looks around only for trophoectoderm, not for the inner cell mass. Right. So this could be normal, this could be abnormal mosaicism, but you identify that we are having a partial mosaicism in the placenta. Right. So the NIPT can turn out to be false positive, and the baby is normal. The baby is normal, so we are having a complete abnormal placenta. So the NIPT can turn out to be false positive. Here we identify that there is a mosaicism in both these things, right? So that is how it is. So this is the background. So this is the background. Now this is what we call it as a CPM. Now what happens is that the placenta can tolerate the CPM, but then this CPM is not detected in the amniocentesis, right? And if the baby is aneuploid, the baby is anyways is going to. If the baby is aneuploid babies will spontaneously abort. So meaning thereby that so all these things on nut and shell, we can have a mitotic and we can have a meiotic, right? In mitotic, we can have the trisomy in the trophoblast, we can have in the mesenchymal stroma, we can have in the fetus. If it is a meiotic, all together everything is aneuploid, right? How does it make a sense in the clinical scenario? Is this that this is a CPM, don't worry about all this part, but try to look around in here. If we are having a meiotic, we would have a UPD, right? So please make a note of it. Iska dhyan rakhiye. We will talk about this CPM, we'll talk about this UPD later on, right? Now we can, as I've told you, mitotic CPM तीनों में हो सकता है. We can have a trophoblast, we can have extra embryonic coelom, we can have in the baby also. In meiotic, what happens? The trisomy rescue is there, but it is having an UPD, right? So why this is important is this, that probably we can have a CPM of three varieties. So CPM 1 and 2 are usually mitotic, and 3 is meiotic. Type 1 is really common. Type 1 CPM is really common. So, right, and the CPM happens in something around 2% of the fetuses, 2% of the pregnancies. If the CPM is there, type 1 CPM is there, up to 20%, we can land up with all these things. So imagine a situation in which we have done some screening tests, it's turned out to be positive for trisomy 18. We have done the amnio, it has turned out to be normal, but then also the CPM element remains, and then IUGR and IUFD. So probably down the day we are going to talk about a lot of things across about the IUGRs, right? So the placenta is the culprit, and therefore it is making the baby at risk. So this can even lead to false positive. So probably that we know that the placental genetic makeup might not be always identical to the fetus. If we are having a demise fetus, we actually need to wait for 6 more weeks before we can really do this NIPT test. Then maternal mosaicism is also there. 50% of the females greater than 50 years of age are going to lose one X chromosome. Let me come back again. 50% फीमेल्स 50 साल की उम्र पे अपना एक एक्स क्रोमोसोम लूज कर देंगी. So if we do the karyotype, there would not be any clinical indication of doing a karyotype of a female who is at 48 or 50. But eventually, if we do that, we identify that they are Turner mosaic. So they are losing one X chromosome. So this mosaicism, those in an elderly mosaicism might lead to these false positives. No call when it is the FF is less than 4%, and therefore they are usually lower because of the placental site, because the placenta is small, and once it is a no call, it is an invasive testing should be recommended. So NIPT is a screening test. It is just an estimate. It is absolutely an estimate. For twins, it is slightly more complex because we identify that we can have a DADC or we can have a DAMC twins. So DADC twins, इट इज कॉल्ड एज ए मास्किंग फेनोमेनन. मास्किंग फेनोमेनन ऐसा है कि दो बेबीज मेरे पास में है, एक बरगद का पेड़ है, जो बड़ा पेड़ है वो ज्यादा डीएनए माँ की बॉडी में देता है एज कंपेयर टू द स्मॉलर वन. सो द बिगर और द नॉर्मल डीएनए masks the aneuploid fetus, right? So higher contribution from a normal and therefore leading to a false negative. So as we have discussed, we can have a trisomy rescue and we can have a maternal mosaicism. Vanishing fetuses, the CRL is also very, very important because if we are dealing with the twins, we actually, all those data, they look around for the CRL, but the CRL are discordant. So the smaller fetus is bound to have more chromosomal abnormalities, right, as compared to the babies who are bigger. NT also is very, very variable. In a DADC twin, we identify that there could be some chromosomal abnormality. We can have a cardiac. And in a DAMC, we can have TTTS or TAPS. Now, as far as the fetal fraction of twins is concerned, what we identify that it is not something 2 times of the fetal DNA which is available in the maternal blood. It is only 1.6 times, right? And second thing is this: we can have a masking, we can have a heterokaryotypia, we can have a small amount of fetal DNA per fetus available in a DADC or DAMC twin. Third thing is this: you have to always reduce 10% of whatever is the sensitivity of the NIPT in singleton. I'll come back to this again. Whatever is the sensitivity of the NIPT, whether it is somebody is telling at 90%, 99% for a singleton baby, whenever we are dealing with twins, we have to reduce 10% to it, right? So it gets reduced by 10% and 22% whenever we are talking about trisomy 18 and trisomy 21. Now NIPT failures, they are very common because of the masking phenomenon, bigger twin giving more DNA as compared to the smaller one and therefore masking. In a DAMC twin, we have identified heterokaryotypia can be there, so fetal fraction can be less, we can have a demise, so this becomes heterokaryotypia. So we have had one case in a DAMC twin. Every now and then we have had those cases in which we have missed looking around for aneuploidies. So this can be very well explained in a DADC twin because we identify genetically they are different and might not capture both of them, but in DAMC we identify that they should genetically they should be the same, but then this is a known phenomenon. We have also published one of the paper across in which we have identified that there is a heterokaryotypia which happens in a DAMC twin, so genetically they are different. Now there is a lot of hue and cry regarding the NIPT and microdeletions. So let us come clean on those microdeletions, right? Fetal fraction for a normal chromosomes that we are talking about should be greater than 4%. For microdeletions, we should be actually 8 to 10%, right? Low fetal fraction less than 4% can lead to false negatives, especially for a microdeletions. Now this 22q is the commonest microdeletion that we are talking about, right? Okay, so URSA can be there, right? URSA is one of the indications in which we identify that there could be 22q, right? And then we can have the 1p36 is the second commonest microdeletion, and then we do have all these things. But now you look around in here, if the area of microdeletion which is under evaluation, it is less than 3 MB and the fetal fraction is 10%, the sensitivity drastically drops down. For microdeletions also, so we can have a CPM, but try to look around in here. Maternal microdeletions can be misinterpreted as a fetal, right? So what we have identified, that NIPT with microdeletions, if they turn out to be positive, 65% we have identified they are false positives. Now the false negative is this, that probably we need to be very, very sure about the fetal fractions when we are talking about the microdeletions, right? So they should be in the range of 8 to 10%. The small size of the deletion, if it is less than 3 MB, so probably it would not be picked up. It would not be picked up. And then if it is a very high GC content, so might get underrepresented. So for all nut and shell, NIPT should not be used as a first line for microdeletions. And CMA or targeted FISH and QFPCR can be done, and false positivity rates and variable sensitivity is also there with NIPT of microdeletions when we are talking about. Now let us talk about 22q in a greater detail, right? Okay, so there was a lot of confusions across. There are a lot of recommendations, those who have come and they say that 22 can be used, 22 microdeletions can be used, okay? But to put the perspective in the right context, what I'm trying to tell you is this: the 22q can have this A, B, C, D, right? So we can have these 3 deletions, right? Right, you're getting my point? So meaning thereby that it is a it is an homologous area. So it is not something that, so we can have these 4 deletions involving this 22q area. Now this is a typical one. This is a typical one, but probably we can have A to B, B to C, and C to D, right? So our sensitivity or the phenotype also changes depending upon the deletion that we are having. So we can have a conotruncal malformation, even though we can have all these things, but these nested and distal deletions, they might be missed on NIPT, right? So meaning thereby that we need to have something around 8%, 8%, 10% of FF, fetal fraction. And if it is a small and the nested deletions, if these two deletions, if these two are deletions, they would not be picked up. So if these are these 2 deletions, if it is a typical deletion, so this can be picked up. This can be picked up on NIPT, but these nested and distal deletions, they would be missed on NIPT. So NIPT would not be able to identify all the microdeletions involving 22q, which is the commonest microdeletion. Now this is a conference in which we identified that there would be some 10-12 fetal medicine people would be there, right? Okay, so this is my last slide. So probably, so this is what all, there could be some more thing that probably we can talk about this, but every now and then we are doing all the maximum best possible to any of the fetus. We can do the microarray, we can do the WES, whole exome sequencing, but even then also the answers are not forthcoming for the questions asked. So meaning thereby that everybody would concur with me that whenever we are suspecting skeletal dysplasias, we are identifying the growth retardations and all those stuff, even then also if the patient is willing, that I am willing to do all the investigations, whatever you say, that we do the amniocentesis, we do the CMA, we do the WES, then also the answers would not be forthcoming. The answers is why, right? So meaning thereby that this WES and CMA, they might be negative and they might not answer all my clinical answers. So probably I should know the answers why this is happening, ऐसा हो क्यों रहा है मेरे साथ. So meaning thereby the WES might have an incomplete coverage. So for a GC rich areas and repetitive areas, they might even miss. So WES would not answer will not answer all the questions asked. Now as far as the array is concerned, array is small deletions and copy number variations, they would not be even picked up by CMA, right? And if we look around, the baseline risk of a chromosomal translocation is something around 1/500. So this frequency has always stayed the same, right? हर 500 में से कोई एक आदमी क्रोमोसोमल ट्रांसलोकेशन का कैरियर हो सकता है. वेदर दिस कुड बी बैलेंस्ड और अनबैलेंस्ड हो तो हमको फिनोटाइप से पता चलेगा, बट वी आर नॉट लुकिंग अराउंड फॉर देम. सो द फ्रीक्वेंसी हैज़ नॉट रिड्यूस्ड, उसकी फ्रीक्वेंसी कम नहीं हुई है. So meaning thereby that WES and microarray, they would miss inversions, they will not pick up translocations, and we have identified that cryptic and complex translocations in the chromosomes are also there, right? And mosaicism, and definitely the mosaicism would also get missed. So meaning thereby that there could be some thing going on in the promoters and the enhancers and deep intronic areas which the WES is not going to pick up. So we'll miss on this thing. Then remains in epigenetics. So probably you try to look around in here. So probably we are going to talk about a lot of things across about the growth restriction to the baby. So in those we have identified the UPD to involving all of the chromosomes. Right. So gone are those days in which we were talking about कि whether you are married in a blood relation, consanguinity के बारे में हम पूछते थे कि आप whether you are related in a blood relationship. The answer is not there. If you go to Bhopal, if you go to Indore, if you go to some Gujarat place, it is very common in down south in which they are marrying in the same community, right? So it is called as an endogamy, right? It is very recently I came across with somebody who had come from Uttaranchal and then they are getting married in the same community for the last so many years. So 3 generation के बाद में the genetic pool gets mixed up. So it is as good as an consanguinity. We can ask direct questions कि आपकी और आपकी वाइफ की क्या blood relation में शादी हुई है? They would get offended, might get offended, say no doc, it is not like this. But then probably we need to refrain and we can refine our question like this कि are you married 3-4 generation in the same community कि भाई 60 किलोमीटर दूर ही मेरी या मेरी है ना, everybody is getting married in the same locality. So what we've identified is this 3 जनरेशन में जाके वो जेनेटिक पूल सेम हो जाता है. So उसका होने का मतलब ऐसा होता है कि that probably we can have an UPD. So we can have an UPD and therefore we can have this Russell Silver. So we can have a polygenic and multiple. हाँ जी
क्लियर कर दो. डायरेक्टर डॉक्टर वीरेंद्र इज हियर नाउ, MCH हरियाणा.
अच्छा. I would I would have your attention and so that is how it is. And so this is what I have told कि balance translocations are missed, epigenetic mutations are missed. We don't have any idea about what is happening with the non-coding regulatory variants, structural rearrangements, epimutations, deep intronic variants, and some mosaicism, and therefore we might miss on these investigations what we are offering them. So what do we do now? What do we do is this, that it is very difficult. It is very difficult to ask for all those investigations. Now who is going to pay the food, who is going to foot the bill and all this stuff. So we can ask for WGS, which I believe would look around for deep introns. We can ask for RNA and then probably we can look around for their expression profile. We can do a methylation studies and all those stuff, but not a lot of labs are coming forth and they are doing those methylation studies. And then probably we can do those karyotype. Karyotype is very, very important whenever the answers are not coming. So karyotype is very, very important. So screening. So probably screening is very, very important so as to identify and to give these healthy babies to the parents. I really thank you.